Thank you. We shall go on to our next speaker, Dr. THENARASUN, who's a senior vitreoretina consultant from the Eye Foundation Group of Hospitals based at Coimbatore. And he's going to talk on, again, a very important topic, post-traumatic endophthalmitis. On to you, Dr. THENARASUN.
Ma'am, I think, good evening, everyone. I thank Yassi and Chitra ma'am for giving me this wonderful opportunity. So I'll be talking about post-traumatic endophthalmitis. So incidence approach 11.9% in case of open globe injuries without intraocular foreign body. It comprises almost around 50% cases of endophthalmitis. So this is a case of a 5-year-old male who had a hair blast injury. He underwent pericorneal repair, perforation repair elsewhere, and presented 2 weeks later to us. He had a traumatic cataract with zonal dialysis post-repair, and the ultrasound shows severe vitreous issues with membrane loculations, and he was planned for postprandial lensectomy with vitrectomy with intravitreal antibiotics. So this is the surgical video. These hooks were used to enlarge the pupil, following which 3 postprandial ports were inserted, and infusion is checked whether it is a chest cavity, following which postprandial lensectomy was done. And there was a dense vitreous.
I think his net is.
Yes.
Dr.
He's
The
lost.
slide is...
THENARASUN, are you there? No, there is some huge weather issues here.
The slide
THENARASUN?
is frozen.
No, I think he has had a network problem. THENARASUN, could you may have to connect on your phone or change your network?
I think he's logged out now.
No. I think there's a terrific rainfall here.
We can just
move to the next speaker. Yeah, we go on. THENARASUN, THENARASUN is starting the screen. Yeah, we'll just give him one try.
I think I'll switch off my video. I think there is a poor network issue.
Yes.
So this was a case of the video of the patient. Iris hooks were used to enlarge the pupil, following which 3 postprandial ports were inserted, and postprandial infusion was checked, following which postprandial lensectomy was done. There was a dense vitreous accretion behind the lens with a vitreous hemorrhage sheet. It was cleared off. Space was created for the vitrectomy, and you can see there is a dense vitreous membranes along with the exudates posteriorly, and core vitrectomy was done. Once the core vitrectomy was done, the exudative layers were removed, and you can see the retina behind, and the thorough peripheral examination was done, base dissection was done. Infronasally, there was a localized retinal detachment. A suspicion of intraocular foreign body was made, and there was a foreign body which was embedded subretinally, which was retrieved out, and it was delivered out through the clear corneal incision, and it was brought out with the help of foreign body intravitreal forceps. And again, there was one more intravitreal foreign body, which was again noticed, which was embedded in the choroidal layer. The nature of foreign body is a stone. So again, you can see a second stone which is embedded in the choroid, which was again retrieved. It was brought out anteriorly through the clear corneal incision. And once it was done, the retina was settled, fluid exchange was done, endolaser was applied with a break, silicone oil injection was done, retina was settled, and intravitreal antibiotic injection was given. Patient is left aphakic. The best corrected visual acuity was 660 at the end. So what are the clinical characteristics? Most often patient presents with severe pain. So how do you differentiate from the traumatic pain? Usually the traumatic endophthalmitis will have excruciating pain along with a purulent discharge, hypopyon, severe anterior chamber reaction, along with traumatic cataract, vitritis, and retinitis. This plays a crucial role. It should be done as early as possible within the next day of primary corneal or scleral perforation repair. You have to look for dense vitreous exudates or detachment, or in case of some foreign body, intraocular foreign body also has to be looked for. The other investigation modalities should be done. In cases of metallic injury, X-ray orbit AP lateral should be done. In other radiolucent or radiopaque capacities, computed CT scan should be done. At least less than 1.5 to 2 millimeter cut sizes should be done to rule out any intraocular foreign bodies. This is medico-legally very important. So Ocular Trauma Society severity, they have based scorings, which is based on the presenting visual acuity with other clinical features, based on which the outcome was prognosed. And there are certain high risk and prognostic factors. So depending upon the mechanism of injury, if there is a penetration or perforation and rupture, and along with the intraocular foreign body, the chances of infection is very high and the prognosis is very bad. And the injury site, if it's a workplace and outdoor, the chance of mixed microbial microorganisms is very high. And again, the chances of infection and prognosis is bad. Depending upon the object which causes injury, if it is a contaminated vegetable matter or soil or wood, the chances of organism and the chances of traumatic endophthalmitis is very high, whereas in compared to the metallic objects. The zone of injury is very important. Zone 1, which is the corneal and limbus, the direct entry of commensal organism is very high, and these type of injuries are more prone for traumatic endophthalmitis. Those who have lens capsule breach, vitreous prolapse, and uveal tissue prolapse have high chances of traumatic endophthalmitis. Associated retinal and choroidal detachment will have poor prognosis. The patients who presents late than 24 hours of injury to the hospital has high chances of traumatic endophthalmitis and poor prognosis. So this is the microbiological spectrum. Most commonly, gram-positive organism is seen post-trauma. Commensal organism, that is Staphylococcus epidermidis, is most common, whereas Bacillus cereus infection is very life-threatening. It has a very poor prognosis. Most often, they end up in enucleation or evisceration. Mixed microbial organism is a trend in traumatic endophthalmitis because of the modality of injury. So intraocular foreign body, it can directly cause mechanical injury. It can carry along with, it can cause a reaction. So the metallic foreign body, iron, copper, nickel, mercury can cause a toxic reaction, whereas vegetable mud, stone can cause infective reaction. Whereas gold, silver, and platinum are inert, and other non-metallic objects like glass, porcelain, rubber, can cause very minimal reaction. So how do we manage? Vitreous tap biopsy should be done, along with intravitreal antibiotics should be given to cover both gram-positive and gram-negative. In case of suspicion of fungus, amphotericin B should be given. The systemic antibiotic plays very important role in cases of traumatic endophthalmitis compared to post-operative endophthalmitis. Here, in combination with intravitreal, it should be given at the time of repair as well as at the time of diagnosis of traumatic endophthalmitis. It helps in improving the prognosis. So vitrectomy plays a pivotal role. So early vitrectomy is the key. So for early vitrectomy, the diagnosis is very important. It is very challenging in cases of traumatic endophthalmitis because most of the patient will have corneal sutures. Media will be very hazy. There will be hyphema. There will be dense inflammatory membranes, traumatic cataract, and there might be retinal detachment along with it. So the advantage of vitrectomy is that it helps in reducing the inductive load. It helps in identifying the organism. It clears the media. It blocks the inflammatory chain. It treats a complication like retinal detachment. It helps in removing the intraocular foreign body. We can directly deliver the intravitreal antibiotics. The key point in vitrectomy is that avoid violent PVT induction. Aggressive peripheral vitrectomy should be avoided. Rapid suction should be avoided. So alternate intravitreal antibiotics like piperacillin, tazobactam should be considered in cases of Pseudomonas. In cases of Bacillus and Clostridium, clindamycin should be considered. In fungal, we have amphotericin and voricosol. So what are the roles in traumatic endophthalmitis? Most often, patient will have associated retinal detachment, and after clearing the vitreous and settling the retina, silicone oil helps in settling the retina. And again, bacteria cannot multiply within the silicone oil. It provides a clear media as well. And in case of inadequate removal of vitreous, definitely silicone oil shouldn't be injected because it creates compartmentalization. So in conclude, post-traumatic endophthalmitis has worse visual prognosis compared to the post-operative endophthalmitis. The close monitoring of cases post-trauma and the early diagnosis and the treatment forms a key role in cases of management of post-traumatic endophthalmitis. Thank you.
Very nice talk, Dr. THENARASUN. Two very basic questions I'll ask. So what would be the prediction of the final visual acuity in a post-traumatic endophthalmitis, and how would the location also decide?
Yes, ma'am. Most often, the zone 1 injury has a high chances of traumatic endophthalmitis because it has a direct entry from the cornea, the commensal organisms, compared to the posterior zone 3. Whereas, as I showed in the thing, there are different parameters. The patient who had initial poor visual acuity, those who had a breach in the lens, those who had a zone 1 injury, and those who had traumatic retinal detachment along with it, and those who have bacillus cereus infection. These are all the worst prognosis. These patients will have poor visual outcome.
Dr. Natarajan, I didn't know you had got connected again. Would you want to add anything at this for this question?
Visual prognosis will depend on the. Can you hear me?
Yes, yes.
Yeah, no. The visual prognosis will depend on the point of injury, right? The center of cornea, the center of macula, and the optic nerve. But I think otherwise, if it is endophthalmitis, again, depending on the virulent organism. If it is a bacillus, we have to really do it in an emergency. And maybe in hours, the eye can go, like the entire, all structures will, and we have to also change it. Can you hear?
Yeah.
No.
Yes. We just give you one try.
So I think the endophthalmitis, the traumatic endophthalmitis prognosis is poor, and we have to really treat it aggressively. And in case sometimes you need antibiotic, intravitreal antibiotic, depending on if it is a fungal, antifungal, and if required, even silicone oil has to be injected.
Yes. Thank you, doctor. Yes, I think we have 2 more speakers and we need to take do just